Welcome back, everybody, to Management of Antibiotic Resistant Pathogens. We have this afternoon Dr. Zachary Willis, who is here to make this presentation. Dr. Willis completed pediatric residency and fellowship in pediatric infectious diseases before joining the faculty of the UNC Department of Pediatrics in September 2016. The focus of his research during fellowship and as faculty has been on antimicrobial stewardship. Dr. Willis's research is primarily focused on promotion of appropriate use of antibiotics in children in both inpatient and outpatient settings. Dr. Willis serves as the director of the Pediatric Antimicrobial Stewardship Program for UNC Healthcare. And in that capacity, he closely follows the epidemiology of highly drug-resistant organisms and current evidence-based strategies for optimal treatment. He's the perfect presenter for this topic, and we welcome you this afternoon, Dr. Willis.
Thank you very much. That was very kind. Thank you, everybody who is listening. Sorry we can't do this in person. This conference is star-crossed. Do I have until 2:45, Amy?
Yeah, at least. And if we need to go over to 3, no problem.
Okay. All right. All right. Thank you very much, everybody. Let's see. There I guess. Okay. Oops. All right. So just a quick overview. I want to talk a little bit about the burden of antibiotic-resistant organisms, mostly bacteria, but some fungi. I'll talk a little bit about critical antibiotics, including ones that are currently in use, and a little bit about new development. And I'll talk about diagnosis of antimicrobial resistance. Then I want to go through the most important antimicrobial resistant pathogens of epidemiologic significance. So in the gram-positive category, that would include Staph aureus and Enterococcus. Gram-negative, ESBL, carbapenem resistance, and others in that class, and then some antifungal resistant Candida species, including some emergent ones that you all have probably heard about. I think we can move on past that. I'm not a clinical microbiologist. So there might be things specific to microbiology that I do not know the answer to. And then, of course, this is a very large topic. It's really like kind of most of my job. So it's way more than we can cover in an hour. But hopefully we can hit on the big topics. I think this audience is probably familiar with this data and this specific slide as well from the CDC report from 2013. 2 million illnesses and 23,000 deaths annually due to antibiotic resistance. And the C. diff is not the focus. There's also lots of C. diff illness, 250,000 illnesses and 14,000 deaths per year. All of these are probably underestimates. So what are the factors contributing to spread of antimicrobial resistance in hospitals? So patient factors, and I think this will be familiar to most. Severity of illness, so the more critical your illness, if you're familiar with SOFA score, the higher your SOFA score, the more comorbidities you have. Immunocompromising conditions, so transplant recipient, an oncology patient, and patients with immunodeficiencies are going to be at greater risk. Medical technology and procedures, so LDA, lines, drains, and access, open wounds are all portals for infection and also opportunities for colonization with antimicrobial-resistant organisms. Infection control is a factor. I guess it's not fair to call it a factor contributing to spread in hospitals, but affecting the spread in hospitals. We do see, but from that standpoint, increased introduction of resistant organisms from the community and residential facilities. And if you have ineffective infection control and isolation practices, particularly compliance, that could contribute to the spread in hospitals. Antibiotic overuse is kind of my primary focus. And so that touches on things like increased use of antimicrobial prophylaxis, increased use of polymicrobial antimicrobial therapy. So using lots of antibiotics at the same time, and particularly lots of antimicrobial use in intensive care units contributes to the development and spread of antimicrobial resistance. So this is an old chart from 2004 from the IDSA, but I include it just because it has some good historical data. So the blue dots are MRSA, and this is the, can you guys see the cursor, Amy? I don't know. Back in the 1980s, there was essentially no MRSA in the early 1980s, and then it took off as a hospital-acquired pathogen. This is the percentage of all Staph aureus isolates that are MRSA. But then it really took off in the late 80s from being almost unheard of. So 2 to 5% of isolates in the early 1980s. By 1990, almost half of Staph aureus isolates were methicillin resistant. It plateaued there for a while, and then we had another epidemic, and this is the community-acquired MRSA epidemic that started in the late 90s and early 2000s. So just, if you can imagine, if you were practicing medicine here in 1984, and then the switch over a 4 or 5 year period to 1989, you're really seeing a huge increase in antimicrobial resistance. And then that's been mirrored by VRE, although VRE has not quite reached the same heights. But you can see all of a sudden VRE is never heard of, and then becomes 25% of healthcare associated enterococcal isolates by the early 2000s. And then the black dots are fluoroquinolone resistant Pseudomonas, which was quite rare and quickly became very common. So really, I think what's striking here is that these things develop pretty quickly. From that same 2013 CDC report, they tracked antibiotic introductions and antibiotic resistance identification. I think there's a few that are worth pointing out. Methicillin was invented in 1960, and the first methicillin-resistant Staphylococcus appeared in 1962. That didn't take very long. Imipenem was invented in 1985. It actually took 13 years before we saw imipenem-resistant Enterobacteriaceae. Ceftazidime was also introduced in 1985, and resistance appeared just 2 years later. Ceftaroline was introduced in 2010, and the first ceftaroline-resistant Staphylococcus aureus appeared in 2011. So these can happen in just a year or two from the introduction of these antimicrobials, some of which were actually quite novel, and I think they didn't really anticipate that this could happen. So why does this happen so fast? Well, most antibiotics are microbe-derived products. So penicillin, we all know the story, or all have heard the story of penicillium, the mold that was growing on Alexander Fleming's plates that killed, forget if it was Staphylococci or Streptococci, that he was actually trying to grow. Cephalosporins come from a mold called Acremonium. Carbapenems come from a bacterium in the Streptomyces genus. Vancomycin is a mold product. Tetracyclines, polymyxins, and amphotericin are all microbial-derived products. So they've been producing these things mostly, in the dirt or in water to fight each other for resources, and they've been doing this for billions of years. So the genes for resistance to these things are in their genetic pool, even if those genes are out there, even if they're not present in a high percentage of organisms, or they might be suppressed. So in 1998, when these principles of antibiotic resistance were published, given sufficient time and drug use, antibiotic resistance will emerge. Resistance is progressive, evolving from low levels through intermediate to high levels. Organisms resistant to one antibiotic are likely to become resistant to other antibiotics. We see that a lot with like ESBL and CRE. They're usually resistant to most other things. Once resistance appears, it is likely to decline slowly, if at all. I think we definitely see that. There are some good stories, but they're few and far between. The use of antibiotics by any one person affects others in the extended as well as the immediate environment. So that's really like kind of the core of antimicrobial stewardship, that overuse of antibiotics for one patient can actually harm their neighbor, which is rare when we talk about adverse effects of medications, or unique. So how antibiotic resistance happens, again, I think this is pretty basic microbiology, but you've got lots of germs. Imagine your patient's colon, trillions of bacteria. Antibiotics kill the bacteria, so you put them on a broad spectrum antibiotic, and all these bacteria die. And who's left? Just these purple resistant guys, and then they expand, in your patient's GI tract. And actually, some bacteria, sometimes they can actually transfer their resistance elements from one organism to another, and this can cross species in some cases. Because we have many more bacterial cells than human cells, and when we get exposed to antibiotics, it really does select out those resistant organisms. In fact, it's surprising that resistance doesn't happen even faster than it does. A lot of this is also not, it's not just the hospital or not just humans. This figure is also from the CDC, and what they're trying to pull in on the left side is not just the human cycle of antimicrobial resistance, but also the animal cycle. Animals get antibiotics and can develop resistant bacteria. Their stool gets used as fertilizer, or the runoff from the fields gets into water supply. That fertilizer then gets sprayed onto lettuce, and that can then be ingested in humans. So that's one portal for antibiotic resistant organisms to get to humans. The other way is for this guy to go into the hospital, get antibiotics. He can spread antibiotic resistance horizontally within the hospital, who then go home. But then he goes home and he can spread those to his contacts outside of the hospital. And so you can see people who have antibiotic resistant organisms who have never had significant antibiotic exposure, but maybe have a family member who has, for example. And that human cycle kind of gets to the modern care continuum. There's people who are back and forth between the hospital and skilled nursing facility. Maybe there's stops, maybe they're going home as well, but they're coming into contact with a lot of different people in a lot of different environments, each with their own risk factors for exposure to antimicrobial resistance. And certainly we're seeing that we're seeing a lot more push for controlling this on the skilled nursing facility side. But any break in this, so you could have great antimicrobial stewardship and infection control in your hospital, but if you're sharing patients with a skilled nursing facility with inadequate infection control or inadequate antimicrobial stewardship practices, you're going to get those antibiotic resistant pathogens into your hospital with the patients. So the CDC promotes 4 core activities to fight resistance. 1 is to prevent infections and prevent the spread of resistance. 2 is tracking, so obviously keeping track of these. And actually, we don't do a good job of this. We don't know when a patient is transferred from one facility to another. We don't always know what sort of antimicrobial resistance they're known to have. Improving antibiotic prescribing and antibiotic stewardship, and then developing new drugs and diagnostic tests. So in the antibiotic pipeline, there are new antibiotics being developed to stay on top of highly resistant organisms, but only 10 antibiotics have been approved since 2010. At any given time, there are about 40 new antibiotics in development. Historically, about 1 in 5 will make it to market. There are a lot of barriers to new antimicrobial development. Most importantly is limitations on sales. When a pharmaceutical company develops a new product that's targeted to highly resistant organisms, that's still a very small niche. And they're also, would you rather make an antibiotic that's going to be used for 14 days or a statin that's going to be used for the rest of the patient's life? Probably, you're going to invest in the statin. And then antimicrobial stewardship, unfortunately, it's a little bit of a paradox. As soon as a new antimicrobial product hits the market, we immediately, box it off and make sure that nobody uses it. So that really doesn't encourage new drug development, even though we want new drug development. There have been some recent policy fixes that seem to be helping. With extensions of patent protection and a lower bar for FDA approval, but when you do lower the bar for FDA approval, you might not have as much information about safety and efficacy as you would for other classes of medications. So these are those drugs since 2010. Going back to ceftaroline, which is a cephalosporin that kills MRSA in 2010. Telavancin, which has been around for a while in Europe, but was approved in the US. 2013 was a banner year. The important one there is ceftolozane tazobactam, which really broadened our armamentarium against resistant Pseudomonas. And then ceftazidime avibactam was the first beta-lactam class drug that was really focused on carbapenem-resistant organisms. And then meropenem vaporbactam was added last year. Delafloxacin is really targeted more at skin and soft tissue infections. It isn't a major solution. And then there's a new aminoglycoside called plazomicin, and there's new tetracyclines and other things that are in development. And then what we really need to be focused, what we really should be worried about is the resistant gram-negative infections. I didn't include antifungals. There haven't been a ton of new ones, but there is some movement on that front too. All right, so I said I would talk about particular groups of organisms that are really important and then how we manage them. So Enterococcus, ampicillin resistance, or vancomycin resistance, Staphylococcus aureus, we talk about oxacillin resistant or methicillin resistant MRSA. Clindamycin resistance and Staphylococcus aureus is also kind of a big problem for outpatients. And vancomycin resistance is a specter that is out there, but really hasn't become an important problem, though it could one day be. With gram-negative enterics, the two big important groups are ESBL and then, of course, carbapenem-resistant. CRE stands for carbapenem-resistant Enterobacteriaceae. Pseudomonas, Stenotrophomonas, and Acinetobacter, so there's non-lactose fermenters that can have all sorts of weird mechanisms of resistance. And then fungi, the two important species to talk about, Candida krusei and Candida auris. Candida auris is a particular interest for an infection prevention audience. I just included this. The escape pathogens was, kind of a catchy name for some of these organisms that are a particular concern. So how do we diagnose antimicrobial resistant pathogens? I'll touch on this briefly because I think most of this crowd probably is fairly familiar with this. Culture is, of course, the gold standard. It does require sampling of the site of infection prior to therapy. And this allows determination of antimicrobial susceptibility. You have the organism and you can do phenotypic testing on it. PCR can also be done, but generally still requires an incubation step. This is used for rapid species identification. And there are some blood culture PCR systems. So you grow your bacteria in the blood culture bottle, and then these PCR systems can quickly identify some resistance mechanisms, so they can tell you 2 hours after the organism grows that it's VRE or MRSA, whereas before that would have taken 2 days. So 2 hours versus 2 days is the improvement there. And those are fairly reliable or highly reliable for VRE and MRSA, although for gram-negatives, there's going to be too many resistance mechanisms for them to detect 100% of those. One thing that we are seeing is a lot more direct detection of bacteria using PCR technology, like from stool and CSF. So a lot of hospitals now, for example, including ours, are using, rather than traditional stool culture, a multiplex PCR that detects Shigella and Salmonella and those sorts of things. However, you do not, the downside of that, it's a lot faster. The downside is that you don't actually isolate the organism and you can't determine if it's resistant to antibiotics. So using PCR is nice and fast, but in some cases you do lose some information that you would have had. So what is an MIC, the mean inhibitory concentration? That's how we define antibiotic resistance. It is a phenotypic test of a bacterial isolate's growth when exposed to a particular antibiotic. It is the lowest concentration of the antibiotic needed to prevent the bacteria from growing. It's generally expressed in micrograms per ml. So basically, that's telling us as clinicians we need to achieve antibiotic concentrations above that number in order to kill the bacteria effectively. It does require interpretation, which is kind of baked into the reports. So this is how it most often works. It's usually automated with machines like a Vitek or Phoenix or Microscan. They place bacteria into all these different tubes of increasing antibiotic concentration from left to right. You see at 0.25, the bacteria grow, they grow, they grow. They grow here at 2.0, but at 4.0, they don't grow anymore. So that is your MIC, that is your MIC value. Another way to do this is, and I like this visual, although sorry, that picture is very grainy. Here you have, this plate has a lawn of bacteria, so it's all bacteria, and you see all these different antibiotics. These discs have antibiotics, and you see this antibiotic disc is killing the bacteria, and this one is killing the bacteria, but it's resistant to all of these antibiotics. And so it's just nice for conceptual. And this is another way to do that, which just looks nice. This is called the E-test, and actually with this one, where the bacterial growth crosses the E-test strip, there's a little, you can't really see them, but there's a little number there, and that tells you what your number is. So there's a few different ways that this can be done by microlabs, and it's helpful to know. It's sometimes helpful to us to know exactly what technique they used. Interpretation is important. So for every relevant combination of species and antibiotic, there's a breakpoint established by CLSI, the Clinical Laboratory Standards Institute. This requires a lot of pharmacologic understanding. So for them to say that, basically, if they say that it's sensitive, they mean that at standard dosing of the antibiotic in your patient, you're likely to achieve antibiotic concentrations adequate to kill that bacteria. So it's not just whatever the MIC number is. It's also based on what sorts of concentrations of the antibiotic you actually achieve in patients. There are some breakpoints that are wrong, however, and for infectious disease specialists and pharmacists, that's really important. So, for example, if Staph aureus has an MIC of less than or equal to 2, that's considered fully susceptible, but we know that outcomes are worse if we use vancomycin and the MIC is 2 than if the MIC is less than or equal to 1, meaning, and by worst outcomes, potentially higher mortality or more treatment failures. So they're not always based exactly on clinical outcomes, although they try to do that, and sometimes, they respond to literature and sometimes have to make updates. One important thing, particularly on the clinical side, is this concept of modes of antibiotic therapy. So when we suspect an infection, we give empiric antibiotics, meaning we think it's a urinary tract infection, or we think it's pneumonia. And we're going to start antibiotics focused on trying to cover 95% of the things that might cause pneumonia in this patient. We don't yet know what is causing the infection. We might not even be 100% sure that, whether it's pneumonia or a urinary tract infection. But we try to cover the most common possibilities. Generally, this means that antibiotics are broad spectrum. There's usually multiple agents, and there's a lot more toxicity from empiric therapy. Directed or definitive therapy means that you know what the infection is, that you've identified the pathogen, you know the susceptibility, and you can focus on that. You know exactly what you're treating. So this allows you to narrow your coverage as much as possible rather than using super broad spectrum coverage that is nuking the patient's microbiome. You can be a lot more focused. And you can, and almost always the directed therapy, you can pick something that's a lot less toxic. But that conversion from empiric to directed therapy doesn't always happen as quickly as it could, and that's a major focus for antimicrobial stewardship, to try to prevent patients from getting exposed to the extremely broad spectrum antibiotics. All right, so what is the impact of antimicrobial resistance? Why do we care? I think, it's somewhat intuitive. Obviously, a resistant bacteria is worse than one that's susceptible. But how does that translate to real outcomes? So empiric therapy may be inadequate. So if your patient, if you always do, if you always pick, let's say you always give everybody with UTI ceftriaxone. That's what we do for children in our hospital. They all get ceftriaxone. If they have a ceftriaxone resistant organism, then we're not going to find that out for 2 days at least. And the patient's only going to get sicker. And if it's a really severe infection like meningitis, it's possible, so instead of a UTI, now we're talking about meningitis, it's possible that, we'll have a bad outcome. If it's a pyelonephritis, they'll probably do okay. But if it's meningitis, that delay may make the difference between survival and mortality. Drugs, once we know about antimicrobial resistance and we're, directing our therapy, the drugs used for antibiotic-resistant infections are usually more toxic. So, vancomycin that we use all the time for MRSA has a lot more renal toxicity than beta-lactam, cephalosporins like cefazolin, and we have to deal with renal toxicity the whole time. Those drugs are also usually more expensive. They're often less effective. Again, the example of vancomycin versus cefazolin. So it's been shown that if you have a patient with that you can treat with cefazolin, but you use vancomycin, their mortality is higher. Cefazolin is just a better drug. It kills the bacteria better. And so if you don't have that option of using cefazolin, then your patient is at risk for worse outcomes. And then a lot of times we don't have an antibiotic that's available PA or by mouth, which means that patients have to get PICC lines. They might have to they often have to stay in the hospital longer. They might have to go home on IV antibiotics, which is extremely disruptive. We're seeing, in pediatrics, one phenomenon or one trend we're seeing is a lot of, urinary tract infections are common in newborns under 60 days of age. And we're seeing more and more of those being resistant to all oral antibiotics. And we're having to treat them with IV antibiotics for a full course in the hospital, whereas they would have normally gone home on oral antibiotics after 2 or 3 days. So instead, they're staying in the hospital for 10 days. So that's hugely impactful. And then the threat of resistance leads to, before MRSA, nobody had to use vancomycin. We didn't have vancomycin-related nephrotoxicity, which is really common. But now that any patient who comes in sick could have MRSA, almost any patient who develops a new infection is going to get started on vancomycin or an equivalent, and that means we're using something that is either probably more toxic, possibly less effective, more expensive, and IV only in patients who do not have resistant infections, and we just haven't found out yet. So the threat of resistance may even cause more harm than the actual antibiotic-resistant organisms. All right, so now I'll run through some specific examples of really critical organisms. I talk about Staphylococcus aureus a lot because it's the king of all bacterial pathogens. It causes community and nosocomial infections. It causes skin and soft tissue infections, bone and joint infections, nosocomial and post-viral pneumonia. This can be really severe. Most common cause of wound infections after a surgery. Bacteremia catheter-related bloodstream infections, endocarditis, and causes the most severe endocarditis and endovascular infections, and causes metastatic infections. So it tends to, patient has an infection in one place and is bacteremic, they may end up with abscesses at remote locations, which is really a feature of Staph aureus. There actually is kind of a good story here. This figure at the bottom right is the antibiotic resistance of Staphylococcus aureus from 1999 to 2014. And this is how many are resistant to oxacillin, or what percentage are MRSA. So in 1999 is 40%. It peaks in the mid to late 2000s at between 50 and 60%. And actually that's come down a little bit. And that was just that one really virulent strain of community-acquired MRSA has kind of peaked and started to subside. And we're actually seeing more MSSA, particularly in the community, than we were a few years ago. I don't think that's because we're using antibiotics rationally. I think that it's just the waning of that one strain. But it's interesting. How do we treat Staphylococcus aureus? So plain old MSSA is pretty easy to kill. Most beta-lactams, not plain penicillin, but nafcillin, oxacillin, cefazolin. There's plenty of options for it. There's plenty of oral options like cephalexin. We talk about MRSA like, this big bad thing, but MSSA can be just as virulent, can cause just as severe infections as MRSA. And so I don't think of MRSA anymore as causing like worse infections. It's just more difficult to manage. But methicillin resistance is common. It's still it's still very nearly half of strains are MRSA. There's some regional variation. And that's caused by the MEK-A gene, which alters the beta-lactam target. And this is detectable by PCR, and that's very highly reliable. We usually treat that with vancomycin. We do have several options. For severe infection, we can use daptomycin and subterylene. For less severe infections, we can use linezolid, which is also good for severe Staph aureus pneumonias. We can use clindamycin, doxycycline, Bactrim. So there are still several IV and oral options for MRSA. But it causes really severe infections, and because it's so common and the threat of MRSA is always out there, this is why we give vancomycin to so many patients with severe infection. We already kind of covered that. Oh, so this is why. So healthcare acquired versus community acquired MRSA. So back in these strains down here in the early 1980s and the late 80s, that was healthcare-acquired MRSA. It first emerged in the 1960s, but really exploded in the 1980s. It was actually much more resistant. It was typically resistant to Bactrim, for example, which is really rare now. But it was less virulent. It caused less severe infections, more along the lines of, it was more analogous really to Enterococcus than the MRSA that we think of right now. But it stuck really well to things like ET tubes and to indwelling catheters. The early 2000s was when we saw the community-acquired MRSA, and that was specifically the USA 300 strain. It just happened to have both. It's MRSA versus MSA. That doesn't make it bad, but these MRSAs that emerged happened to have lots of virulence factors and also happen to be methicillin resistant. So that's why, we think of MRSA as causing really severe infections because of that highly virulent USA 300 strain. But it does seem to have waned. However, we used to think of healthcare-acquired MRSA and community-acquired MRSA as kind of somewhat separate entities, but we don't really, I don't really think there's as useful a distinction between the two anymore, between community-acquired MRSA and healthcare-acquired MRSA, because hospitals are perfectly fine places to find community-acquired MRSA. All right, so in summary, I spent a lot of time on Staph aureus, and there's a good reason for that. It causes a lot of infections, both nosocomial and community-acquired. It's highly virulent, but we do have good options for dealing with it. However, it does drive a lot of vancomycin use. And if you had to choose between having MSSA and MRSA, you would definitely choose MSSA. There is such a thing, I put a little tiny footnote here about VISA and VERSA, so it's vancomycin intermediate Staph aureus and vancomycin resistant Staph aureus. Those are very rare. but they have been described, and that threat is always out there. And generally, those have emerged in hospitals with a lot of vancomycin use, and the Staph aureus just gradually makes a thicker and thicker cell wall that's resistant to the effects of vancomycin. But that's rare, and but if you see one, that's if you encounter Visa in an infection control role, that's an urgent situation. All right, so next organism it's important to talk about is one that, if you're in infection control, this is an old friend, Enterococcus faecium. Enterococcus faecalis is usually not a big deal, but faecium is almost always highly antibiotic resistant. So it causes infections like UTI, catheter-related bloodstream infection, endocarditis, wound infections. It is less virulent than Staph aureus, but it sticks really well, and it's really difficult to treat. There's just some properties of Enterococcus that make it very difficult to kill, or unusually difficult to kill with antibiotics. This is the resistance of Enterococcus faecium in the United States from the same source, and it's not changing a lot, but we just see that vancomycin resistance is around 75% among this species. The real problem, though, is if you see a shift from more Enterococcus faecalis to Enterococcus faecium, your faecium is going to be resistant, but you might have a lot of faecalis, which is not going to cause as many problems. When you do start seeing faecium, that's VRE most often. Most Enterococcus are, good old Enterococcus faecalis is susceptible to ampicillin, which we use all the time, but not cephalosporins, which makes it a little bit fun, a little bit difficult, and it is a little bit hard to kill. Faecium is resistant to ampicillin and usually resistant to vancomycin, so that's your VRE. It's rarely encountered outside of healthcare settings, so you're not going to have healthy people without antibiotic exposure walking around harboring VRE. But it is a major nosocomial antimicrobial resistant pathogen. High-risk populations can be screened with perirectal swabs. So, that's some hospitals do it for everybody, or just do it for immunocompromised populations, for example. So they might do it in their bone marrow transplant unit, oncology units, solid organ transplant units, to screen patients regularly who are going to be at high risk. And then the reason to do that is to isolate them. And then if they get sick, so they start having a fever, and you're worried about that, then you might start, rather than vancomycin, you might start something that's actually active against VRE. Vancomycin resistance is encoded by either VAN-A or VAN-B. These are also genes that can be detected by those rapid ID PCR mechanisms. This changes the structure of the target in the cell wall, and leads to complete resistance to vancomycin that cannot be overcome. Usually, we do still have some options, though. Usually, daptomycin still works, and linezolid almost always still works. So there are options. However, these can be really persistent, thorny infections that are hard to clear. There are some other things that we use less often, like tigecycline, quinupristin, dalfopristin, telavancin. They're also active against VRE. So it's not the end of the world, but it is. These are really challenging infections to clear. All right, those are really the important gram positives, particularly for the healthcare setting. All right, so then now we'll move on to gram negatives, and I tried to make this not too heavy on microbiology, but I think it is worth doing a little bit of microbiology. So bacteria have a cell wall, almost all. Gram negatives, though, so you can see the gram positive on the right has the purple is the cell wall, so they have this big thick cell wall made of peptidoglycan. The gram negative is a little bit thinner, but then the gram negative has this outer membrane. So there's an outer membrane, then cell wall, then inner membrane. And that gives it more control over what comes into contact with its surface. They can regulate this, the space between their outer membrane and their cell wall. So, a lot of antibiotics work by damaging the cell wall, and the gram negatives might be able to deny entry to the antibiotics or pump them out, or get really high concentrations of enzymes that break down antibiotics in that space. So that makes gram negatives a whole lot more complex. So, MRSA is defined by a single gene. There's thousands of genes that might contribute to antibiotic resistance in one species of gram negative rod. So that means the genotype may not predict phenotype, which makes things a little bit more complicated. The lab phenotype may not predict the clinical phenotype in certain circumstances. So the lab might report something that looks susceptible, but could develop resistance over time, for example. Different mechanisms can interact. So with Staph aureus, it's either MSSA or it's MRSA. Enterococcus is either VRE or it's not. But gram-negative rods, particularly things like Pseudomonas, can gradually accumulate resistance mechanisms that pick off different antibiotics. Or these things can work synergistically, where they're like totally susceptible, and then they're intermediate, and then they're fully resistant, and that can develop over time. Gram negatives also like to share plasmid DNA, so they all have their red chromosome, but then they could have any number of plasmids that are transcribed continuously. So that plasmid DNA, they can share it amongst each other. So if resistance elements live on those plasmids, then they can transform their neighbors, and it could be in a different species as well. For Enterobacteriaceae, which is like E. coli, Klebsiella, Enterobacter, Citrobacter, they can all harbor extended spectrum beta-lactamases. This is a large heterogeneous family of enzymes. There's literally hundreds of them. Extended spectrum generally means that they are active against penicillins, cephalosporins, including the fourth generation of cephalosporins, and as Trianam. Our lab, for example, says that if it tests resistance to third generation cephalosporins, so that's ceftriaxone, then that is the proxy for, then we assume that it's an ESBL. ESBL technically means that you have one of these enzymes. The only good thing I could say about ESBLs is that they are still susceptible to carbapenems by definition. If they're not, then it's not an ESBL. And so we do still encounter these, and we do still have carbapenems are a good solution. These are also inhibited by beta-lactamase inhibitors. So the one used most often is tazobactam. So if you're familiar with piperacillin tazobactam or Zosyn, the tazobactam can inhibit the beta-lactamase and allow the piperacillin to actually kill the bacteria. These ESBL is most frequently found in Klebsiella pneumoniae and Oxytoca and E. coli. Those are the two really big bad ones, but can also be present in essentially anything. Acinetobacter, Burkholderia, Citrobacter, Enterobacter, Morganella, Pseudomonas. All these can have ESBL. They are plasmid-based and mobile, can jump from one organism to another. And actually, interestingly, one single type tends to predominate in a region or hospital. These organisms, so in terms of management of these, they do tend to be resistant to other antibiotic classes as well. So, by the time an organism has acquired this sort of resistance, it's often resistant to fluoroquinolones and sometimes aminoglycosides as well. Carbapenems give the best outcomes. Cephalosporins may sometimes test susceptible, but that's still a bad idea. So carbapenems are really the drug of choice. And then, I talked about how piperacillin tazobactam might be active, but in a recent clinical trial for adults with ESBL bacteremia, the group that got a carbapenem had much less mortality than the group that got piperacillin tazobactam. It's not exactly 100% clear why that is, but that makes us think that carbapenems are really the drug of choice. Carbapenem resistance is a thing, though, that we have all heard more and more about. And if you're not a clinician, it's important to talk about the carbapenems. They are our last line beta-lactams. We love beta-lactams because they kill bacteria really effectively, and beta-lactams are also really safe. they're some of the least toxic antibiotics we have. So when we're not able to use them anymore, we run into a lot more problems. So in Enterobacteriaceae, so that's E. coli, Klebsiella, Enterobacter, things like that. Carbapenem resistance is almost always mediated by a carbapenemase, so that's an enzyme that specifically can break down carbapenems, and that's called a CRE. Pseudomonas and other lactose non-fermenters may have other mechanisms that are not enzymatic, like altered porins and efflux pumps that deny the carbapenem access. When you have a CRE, though, they are by definition resistant to all beta-lactams, except for some of the newer agents like ceftazidime, avibactam. So carbapenemases are a major infection control concern. They can jump from species to species because they're plasmid mediated. They're active against all beta-lactams, and they're not inhibited by beta-lactamase inhibitors in general. These have names like you might have heard of KPC or Klebsiella pneumoniae carbapenemase, NDM or New Delhi metallo-beta-lactamase. The people in New Delhi were not happy with that name. And then OXA type or OXA 48. So those are some of the common ones that have emerged in the U.S. And these tend to happen sort of as outbreaks. So, you might hear like a hospital having a problem with an outbreak. This is a worldwide phenomenon, though, and these tend to emerge. These tend to develop not in the United States. We're a global society. So on the left is resistance of Klebsiella pneumoniae to carbapenems. Over here in the U.S., if you're looking at hospital-acquired Klebsiella, about 10% in the U.S. are resistant to carbapenems. In India, it's 57%. That's a real problem. And then this is how antibiotic resistant, how Klebsiella pneumonia resistance to carbapenems has gone over the past few years. So really first appeared in 2005, was unheard of before that. And then it's steadily risen, and looks like as of when this data were published a few years ago, it kind of settled in around 10%. But it certainly could be more because in India it's 57%. So that could happen. Again, these often have resistance to other classes. These are usually, true superbugs. There are other options like tigecycline, but tigecycline has a lot of problems. Polymyxins, so like colistin and polymyxin B. These antibiotics were abandoned in the 1970s because they were too toxic to give to people back then. And we've dusted them off and started giving them to people. When I was in training, polymyxin B was only a topical antibiotic. But we give it IV sometimes now. These are extremely nephrotoxic and neurotoxic and really difficult to manage. And then also they're not very effective. So you're encouraged to use combination therapy. So polymyxin plus tigecycline plus or minus carbapenem. That's kind of beyond the scope. However, some of the new antibiotics that have come out in recent years, like ceftazidime, avibactam, imipenem, vaborbactam, are effective against certain enzyme classes. So I think they're not effective against NDM, but they might be effective against KPC and OXA. So these options are available, and we're trying to reserve them only for carbapenemase producers. Oops. All right, so I talked about, our real last line, colistin and polymyxin B. These are the last line antibiotics for resistant gram-negative infections. However, resistance has emerged. And this is mediated by genes called the MCR genes, MCR1, MCR2, and MCR3. These are plasma-mediated and transmissible. These emerged in food animals in China in 2014 and have now spread across the globe. And you may have heard about this or seen these CDC maps. Turns out colistin is commonly used in agriculture, especially in China. So, we give, most animals raised for food, we give them antibiotics because for reasons that we don't understand, it makes them bigger. And so increases the farmer's profits. And in some places, they're using last line antimicrobials like colistin and just feeding it to the animals. So the organisms are exposed to subtherapeutic concentrations of glycine all the time. Couldn't really come up with a better way to make such a crisis. So I think I updated this. This is MCR genes in the U.S. These are the states where the MCR gene has been found in human isolates in yellow or animal isolates in orange. Still rare, but you also don't know if you're not looking for it. But CDC is setting up surveillance. And you can see it's more common on the coasts and in the populated areas in the Midwest because it's related to international travel. All right, moving on to Pseudomonas, another old friend for this crowd. This is an important cause of ventilator-associated pneumonia, about 20%. Clabsies, about 18%. Catheter-associated UTIs, surgical site infections. These accumulate multiple mechanisms of resistance mediated at the outer membrane, often. If Pseudomonas is suspected, we do consider double coverage for empiric therapy. So let's say you think your patient has ventilator-associated pneumonia. You might do vancomycin to cover MRSA. You might do cefepime to cover, Enterobacter and E. coli and all those, and Pseudomonas. But if you think they're really at high risk, you actually might also add a second antibiotic in case you've got a resistant Pseudomonas. However, we were always taught to use 2 antibiotics to treat any Pseudomonas infection, but we actually don't do that anymore because it doesn't help the patients, but it does cause more toxicity. There's an exception for cystic fibrosis. That's not a lot of time spent on Pseudomonas, but another lactose non-fermenter is Acinetobacter baumannii. And I think, again, it's not as common as Pseudomonas, but causes similar problems. VAT, CLABSI, CALDI, SSI. It's intrinsically resistant to many agents, and this is one that can be classified as MDR, XDR, or PDR. PDR is pan-drug resistant. You don't want that. These resistant infections usually require treatment with polymyxins and tigecycline or minocycline and various combinations. It can be extremely challenging. These were very common in soldiers returning from the Iraq War because Acinetobacter is common in the soil there. So it's still uncommon, but intrinsically poses a lot of antibiotic resistance problems. All right, so in the speaking of highly resistant gram negatives, this was recently published. This case from Nevada in 2016. A pan-resistant New Delhi metallo-beta-lactamase producer, NDM, producing Klebsiella pneumoniae. The 70-year-old woman came home to Reno after a prolonged hospital stay in India, where she had broken her femur and then gotten infected and been admitted to the hospital multiple times in India. She came in really sick to a hospital in Reno, and a wound culture grew pan-resistant Klebsiella pneumoniae. It was intermediate to tigecycline, but that was really their only option. So they tried combinations of antibiotics, but unfortunately there was really nothing to be done. So this is kind of like, these are still rare events, at least in the United States, but this is sort of the boogeyman that we all worry about encountering, just an antibiotic susceptibility report that's all ours. And those things are out there. So how do we prevent resistant gram-negative infections? First, know who our high-risk populations are: trauma, diabetes, malignancy, organ transplantation. LDA, so mechanical ventilation, indwelling Foley, central venous catheters, and poor functional status and severe illness. Strategy is similar to what we've talked about before. Antibiotic stewardship is really important for preventing these. Isolating patients who do have resistant organisms. And then for things that are really important, like if you have a CRE outbreak, then you might consider screening patients in high-risk units for rectal colonization and isolating patients who are positive. All right, I think the last big group to talk about is Canada. There's Candida over there on the right. Risk factors for invasive candidiasis, really kind of similar to a lot of the other ones. Trauma and burns are particularly for Candida. Extremes of age, so we deal with Candida a fair amount in the NICU and in the elderly as well. Having a venous catheter, they like to cause collapses. Candida loves TPN. Broad spectrum antibiotic exposure. Turns out we all have Candida living on our respiratory and GI tract mucosa. It's part of our flora. If you nuke your flora with broad spectrum antibiotics, then the Candida tends to overgrow and can, gets to high enough concentrations, increases the risk of invading. Renal failure is a particular risk factor. Abdominal surgery and GI tract perforations, again, because this is a colonizer of the GI tract, immunocompromised state as well, particularly neutropenia. There's not a huge number of problems with treating Candida. It's very sticky, and it can cause a really severe infection right up front, so the patients can get really sick. And it sticks to catheters really well, so that's a big part of the problem. Fluconazole is actually still effective against most Candida, and that's sort of like that's been our go-to drug for Candida for a long time. Its cousin, voriconazole, has a lot more mold activity, but does cover a few more Candida, but it's a real pain to use. So those are the azoles. The second class is called the echinocandins, micafungin, caspofungin, and inidulafungin. These are great for almost all Candida and have really minimal toxicity and kill Candida really well. So for real Candida sepsis, if the patient's really sick, these are usually the drug of choice. And then amphotericin B is going to kill all but just a very small number of Candida isolates. Very broad coverage. It's also extremely toxic, especially if there's any baseline renal issues in the patient to start with. Antifungal resistance is still rare, but it is creeping. Candida albicans is usually fully susceptible, and this has always been the most common thing. So, with Candida is interesting in that you can usually predict antifungal susceptibility based on the species name. So Candida albicans is usually fully susceptible, but what we're seeing, instead of 90 to 95% of Candida infections being Candida albicans, we're seeing other species that might be more resistant replacing albicans. We don't really see antifungal resistant albicans. That's extremely rare. What you see is just the new species that are tolerant or fully resistant to antifungals. So examples are Candida krusei, which is intrinsically resistant to fluconazole. A rare one called Lusitanii is usually resistant to amphotericin B, which makes it unique, but it's not very common. And then glabrata is often resistant to the azoles, and so those are some of the more worrisome ones. We are increasingly seeing echinocandin resistance, and that's a real problem because those are kind of not becoming the first drug we reach for instead of fluconazole for these infections. The real bad guy though is Candida auris. This is an emerging Candida species. It was a big topic of conversation at ID Week in early October. There have been 427 cases in the U.S. When I made these slides last year, it was 153. So it's a new thing. It's expanding. It's a really important concern for infection prevention. It's been found to colonize patients for very long periods of time, months or years, and it lives quite happily on surfaces. I think that's common to most Candida species, but it can live quite well on surfaces. It's also this will probably get fixed over time. It's often misidentified by automated lab systems, so the lab might spit out some weird Candida species that nobody's ever heard of. It's actually auris because those lab systems, these automated identification systems haven't been updated. So that's something that the CDC will put out a warning, if you see a report that has this random Candida species you've never heard of, that's probably Candida auris and you need to deal with it. Why do we care about Candida auris? The infections have tended to be severe. I'm not sure that they're more severe than any other Candida infection, but they're also resistant potentially to all three classes of antifungals. They're almost all resistant to fluconazole and voriconazole. 30% are resistant to amphotericin B, which is frightening. And then as of when I made these slides, there have been 5 cases that are resistant to echinocandins, and that has developed on therapy. So a patient was doing okay on an echinocandin, which is sort of the drug of choice, but then failed because the candida became resistant. So, there is this like specter of pan-resistant candida that we couldn't have any antifungal for. When patients get these infections, it's not a good situation usually. And if you can't treat them effectively, a favorable outcome is unlikely. This is the most recent CDC map of where Candida auris has been found. And blue means that there's been multiple cases of Candida auris. Again, this is international, so many of the cases in the U.S. have been linked to travel to Southern Asia, South Africa, Venezuela, that presumably were then imported back to the U.S. And this is where the epicenters are. Luckily, North Carolina does not appear here. It's really New York and New Jersey, which is, as usual, they're recipients of a lot of travelers, international travelers. And then some of the surrounding states have a few. None kind of in this part, some in Florida, some in California. Well, I think that's one in California, one in Texas. So they're still scattered, but there's going to be a lot in Chicago, but getting to be more and more. And so this does not seem to be decelerating. The CDC has an email address, candidaauris@cdc.gov. They want to know immediately if you identify a Candida auris. Patients go in single patient rooms, contact precautions, and you really want to be strict with those contact precautions. They want to screen index patients' contacts for colonization, which is that's pretty unusual, I think unheard of for Candida. And then they recommend disinfection with disinfectants that are effective against C. diff spores. So basically, you try to disinfect it like it's the same way you would C. diff. So that's a major concern. It's still not a huge number of cases, but it probably is going to rise. And if we see Candida auris become a significant contributor to all candidemia, there's going to be a lot of morbidity and mortality associated with that. That really is mainly an infection control, not so much an antimicrobial stewardship concern at this point. All right. So how do we deal with resistant pathogens? Kind of bringing this all together. 248. In the community, I always say provide recommended vaccines. If you're vaccinated, you're less likely to get infections, and you're less likely to get antibiotics. Avoid unnecessary antibiotics. Use the appropriate drug to cover antibiotic-resistant pathogens. Provide the appropriate dose and duration. So it's just good stewardship. Don't give people more antibiotics than they need. Use short-course therapy, validated. In the hospital, again, vaccinate patients, including flu shots. Avoid unnecessary antibiotics, infection control. Avoid prophylactic therapy. So we'll see patients who are, sit on antibiotics for months to prevent infection. That's a big no-no. Use appropriate drug to cover antibiotic-resistant pathogens. Practice de-escalation when able. So don't use excessively broad spectrum antimicrobials. And that's all designed to prevent. Lots of references. And then I think that is it. All right, so I will take any questions, I guess, via Amy.
Yeah. So do we have any questions out there for Dr. Willis? We're just going to wait a minute in case. Okay, I guess not.
Everything is perfectly clear.
It's a whole, yeah, cricket situation for us, I'm afraid. Oh, we have a raised hand. Wonderful.
Easier. Questions are a lot easier in
Let
person.
me see if I can get to you. Hold on, Maimuna.
I can see it.
She is. Maimuna, can you?
Great question. Thank you. What are some of the antimicrobial stewardship measures for the outpatient settings? That is a great question. And that's something I'm really interested in. It varies by, what situation you're in. But we do know that probably 80% of antibiotic exposure happens for outpatients and not for inpatients. And we only really do stewardship for inpatients. The fact is that actually most infections in outpatients, this is definitely true for children and also somewhat true for adults. So, you think about COPD exacerbation, group A strep, UTI, skin and soft tissue infection. There is a guideline for from the IDSA or the American College of Physicians, the American Academy of Pediatrics. There's a guideline saying, this is what you should be using for this. And they've generally picked things that are fairly narrow spectrum and try to be responsible in those choices. So, for sinusitis, it's amoxicillin clavulanate. What actually gets used for sinusitis, a lot of levofloxacin, which is a lot broader spectrum and has a lot of unnecessary gram-negative activity. I think there is sort of a gold standard for what we should be doing for most patients with common infections like, COPD exacerbation or sinusitis. And those are clearly not being followed. We don't really have a good handle yet on how to do that. I mean, simply reinforcing the guidelines for people who are not following them is one approach. Unfortunately, it's hard to even get the data at large scale unless you have a large system that you're looking at. But there have been a lot of quality improvement projects. There have been a lot of, reinforcing the guidelines, like basically training the prescribers on guidelines. There's been patient education, attempts to train patients, not to expect antibiotics. We do know that some patients do expect antibiotics and they're more satisfied if they receive them. There's also a big problem with urgent cares have been shown to use antibiotics in a much higher proportion of visits for infections that are probably viral, and they tend to use broader spectrum antibiotics as well. And that, the theory is that that's linked to patient satisfaction, but also, from a more sympathetic perspective, also that they don't have a relationship. They don't know that if the patient doesn't get better, that they're going to call or come back. They're not going to have a chance to follow up. So they tend to be a little bit more aggressive. But it's a big concern, and unfortunately, I think there's a lot of there's a lot that we don't know, and there's a lot of opportunity around stewardship in the outpatient setting. Okay, that was a vague answer.
Maimuna, can you ask your question?
Can you see it, Amy?
She just raised her hand. Let me see.
I saw it typed, and actually, I didn't. And now I realize that I talked more about interventions. It says where. Can you see what are some of the antimicrobial stewardship measures? Okay, for the outpatient settings. For measures, I think what we're looking at is, are you the things that have been used are, if you use ICD-9 or ICD-10 codes that are associated with a virus and you prescribe antibiotics, then that's bad. If you treat strep throat and you didn't send a strep test, then that's bad. That's a well-validated measure. And then if you're using first-line antibiotics most of the time versus non-first line antibiotics most of the time based on those guidelines. Yeah, so Amy, yeah, we can see the question.
Okay, great.
Yeah.
Yes. All right. Well, wonderful. We appreciate you all tuning in this afternoon. And Dr. Willis, we certainly appreciate your expertise and spending the time with us this afternoon. As I mentioned to everybody, we'll see you at 8 a.m. at the Friday Center tomorrow morning. Dr. Willis, thanks so much.
Thank you very much. Sorry we couldn't do this in person this time, but I appreciate it. Thank you all for listening.
Next time. Thanks so much.
Thank you.
Bye-bye.